This is really a collaboration with wonderful colleagues who were sending me some new results and helping me with preparing it even yesterday during the day. So it's a wonderful team with Zuzanna, Raya, Kryštof, and Vanessa. I think I don't have to preach to demographers why is it important to consider age and sex dimension in understanding the dynamics of the coronavirus pandemics. So I can probably skip this part just to emphasize perhaps once more, but you all know it, that the COVID pandemics is really hitting hard in terms of its consequences for health and for mortality, the old population. So there is a very strong age gradient in its consequences. And one of the questions we asked, whether the infection is equally hitting men and women, I will show you quite a number of results related to that. It's possible that women are unequally affected, that they are affected more by the infections because of their patterns of employment and occupation, perhaps also because of some behavioral aspects. The issue when studying infection rates is that the true underlying infection rates are unknown. In most of the countries, in most of the cases, the data we observe and we get to read every day about the officially confirmed numbers of cases, infections, I see them like a tip of an iceberg. You see something above the water. It's better than not knowing anything, but you can only guess the shape of the iceberg and how big is it below the water. It gives you some information, but plenty of things remain unknown because most of the infections in many periods in most countries are not reported, are not detected by testing. Of course, we have the seroprevalence studies and some other ways how to estimate the true levels of infections, but these are not done regularly, and we don't have much data by age and sex for most countries and regions. This selectivity of knowing the infection rates is especially strong in spring when the testing capacity of different countries wasn't still built up, and especially the most vulnerable older groups and special occupations were being tested in spring. So especially during the first wave, the official numbers of confirmed reported cases of infections are not really mirroring what was happening at the time. Just to give you a hint of the differences between what is being reported and what is probably the true infection rates in the population, look at the first seroprevalence studies in Spain listed here above. In spring, when the reported cumulative cases of infections in Spain were about 0.5% of population, the seroprevalence studies suggested that about 5% of Spanish population were seropositive. That means that they experienced the infections in the past months, in the past. So it's about 10 times more than was the reported number of infections. Now we study the officially reported data on infections. I will talk more about these limitations, and knowing all these limitations, with all the limitations in our minds, we ask a number of questions, which I'm not even going to read for the sake of saving times. We make some assumptions when working with such imperfect data. For instance, when we study the ratio of infections among men to the ratio of infection rates among women, we think that probably the testing is probably unevenly affecting men and women of the same age groups similarly. So perhaps it makes sense to relate male and female infection rates, but we will discuss that assumption later on as well. So we are working with the official data on reported coronavirus cases, and our main variables of interest are age, months. So we look how the infection rates progress over time, and gender or sex. In European countries, our data are pertaining to the period up to mid-November. And it's a mixture of individual data for some countries. So in some countries, we have individual records with some very basic characteristics. In some other countries, like Italy, Spain, and England, we work with officially published reports on infections by age and sex, and usually calendar week. We relate this to the population structure by age and sex. And for the countries which report only data in their reports, we try to put together data roughly corresponding to calendar months, but it's not perfect because these reports are published weekly, sometimes even a little bit irregularly. So calendar months is not the same calendar months everywhere, especially in the case of Spain, Italy, and England. And our November data are incomplete, pertaining only up to half of November. This is a very quick, basic information for the countries. We are analyzing altogether 7 countries, which represent 200 million people. We have 5.5 million cases which are reported in these countries. So the reported infection rates vary from 1.6% of population in Italy to almost 5% of the total population in Belgium. And from this very, very basic statistics, you see that in each and every country, there are somewhat more women reported with the infection than men. Now, we have a number of measures we are using in our paper. The main measure is the reported infection rate per 1,000 population by age, sex, and month. So we standardize everything per 1,000 population of a given age and sex group. And based on these standardized infection rates, we compute relative male to females ratios in infection rates. We also look at relative ratios in rates by age related to the overall infection rate in total population or among all women and among all men. And we are also looking at changing age profile, and we discuss the vulnerability of population in terms of age and sex profile of infections. One of the ways we display the results is through heat maps, which show very nicely trends in age and sex profiles by months. And Zuzanna was producing these heat maps just yesterday. To emphasize the fact that we are dealing with different periods of the progression of the virus from the first to the second wave. The first wave, according to the official reported cases, is really just a wavelet. It's very small. As I mentioned at the time, the testing capacity wasn't very high. So you don't see very high infection rates in most of these countries, just a small blip peaking in April. And then from June to August, in most countries, the infections were really subdued. So very, very low rates of infections. That's important to keep in our minds when we discuss all these relative results. And then we have a very strong second wave coming since September and still going on. The decline in November is artificial. That's because we don't have data for all the months. So this is when the testing data suddenly really capture the infection much, much better than in spring because the testing capacity is much bigger. Now let me go to the results so that I don't waste too much time. Are men more likely to be infected than women? How does gender profile of reported infections vary by age? And here we have very consistent pattern across countries. When we take a snapshot of the whole period of the first and second wave combined, at peak productive ages, especially between the ages of 30 and 60, women dominate the reported infections almost everywhere. And at age 40 to 49, there are about 20% more women who are reported to be infected than men. This all shifts after the age of 60, so somehow the age at retirement brings a reversal of this pattern. Between 60 and 80, there are more infected men per 1,000 population, according to the officially reported data, than women. And then this shifts again after the age of 80. Now, to understand how did we compute this and how the patterns of rates look like, this is an example of the Netherlands. So women really have elevated infection rates throughout peak productive ages, according to the officially reported data. For men, this peak is much less prominent. Around retirement, the officially reported infection rates drop, but much more sharply among women. And then in many countries, they go up again among the old population, which is a sign that the vulnerable populations are not really protected well. This is one example of how we analyze this when we look at the progression over time of these patterns from March to November, and by age group, going from 0 to 90 plus age group. All the red fields in these heat maps show elevated ratio of infection. So this is about age. So when you see red color here, these are the ages and months when infection rates are much higher than in the total population. When you see the blue colors, infection rates are much lower than in total population. And the picture for these two countries shows very nicely how this reported progression of infection rates from spring, from first wave to autumn to the second wave, changed the age profile. First, it was the oldest population affected a lot, at least according to the officially reported data. In the summer, when infection rates were very low, it was typically the young ones who were affected most, and we can speculate about the effects of summer parties, summer travel, weddings, all of these things. And then when the infection rates start increasing again in autumn, unfortunately, we have another shift towards elderly profile, towards an older profile of infection, and older populations becoming more affected once again. When we look at it in more detail, one age group by another, we can look at the gender profile of infections in a similar way, looking at what ages women are more likely to be infected according to the officially reported data, and at what ages it is the men who are more likely to be infected. And it's interesting because the picture is quite consistent across countries. From, as I mentioned, from the age of 30 to the age of 60, you see a lot of red here. That means women are more likely to be infected than men. From age 60 to age 80, you see a lot of blue fields here. It means men are more likely to be infected than women, according to the officially reported data. And there is more white in the summer. That means in the summer, the gender profile by age has become much more equal than in the spring. But in autumn, you have a little bit more shift towards female profile at peak productive ages again.
Sorry,
now going back,
Tomáš, 2 more minutes, please.
Okay, now going back to the profile by age, how it was changing over time. Really, the infection rates were shooting up among the youngest age groups below 40 over the summer, and now the older age groups are going up again. You can see the same in the mean age of reported infections. So unfortunately, now they are aging again throughout the second wave, suggesting that more and more elderly are being affected. Now, are these data based on reported cases? Is it really just something real, or is it just very selective result? This is a result of the seroprevalence study in Spain done in the first wave, April to May. We see that the age profile is there, which roughly corresponds to something we observe in the official infections, that the elderly population was affected most, but we don't see any specific gender pattern in there. So the question still remains, from the testing data for England and the Netherlands, we know that women are tested far more often than men at ages 20 to 59, but they have lower test positivity than men. So we don't really have clear answers to our questions, how much the data really corresponds to what's the real pattern. But we think that the fact that there are very consistent results across countries still are suggestive of women of working age is being probably unequally affected by the infection rates, perhaps because of their occupation and employment, with very high share of women engaged in healthcare and social care, accounting for 75 to 85% of the professionals. And we also think that the age shifts which we observe in the data are real, and that unfortunately now the vulnerable populations are affected most. To finish, I can highlight the case of Belgium, which is the country with the highest number of reported COVID-19 deaths per 1,000 population. And in Belgium, we see an extreme concentration of COVID infection cases among the oldest old population, age 90 plus, where 15% of women and 12% of men are reported to have been infected, according to the official data, which are biased downwards. Thank you very much for your attention.